This is Dr. James Kneller. Thank you for joining us. Please subscribe to this YouTube channel and like us on Facebook. And give us feedback by leaving your comments.
Implanting an ICD is like a pacemaker. We start with the sterile drape over the patient. We apply an IOBend patch directly to the exposed skin that we will make our insertion through. I then enter the case. Here I'm getting a sterile gown. I'll have sterile gloves. We have to use absolute sterile techniques for device procedures. We cannot introduce any infection whatsoever. We image the vein with a venogram. There you see the subclavian vein draining into the superior vena cava. This is the vein that we will be implanting through. We then carefully mark the border of the costal margin or the rib cage because we want the ICD to straddle the rib cage on its final position. So there we see our opaque marker outlining the border of the costal margin. I'll mark that with this black felt tip marker and also mark 1 to 2 finger breadths below the clavicle. These are our landmarks for implanting the device. There I'm creating the planned track for our incision that will position that device ideally. We infiltrate 1% lidocaine along our planned incision track, remembering that most of the pain fibers are very superficial, so we want to numb up very superficially. As a priority, we'll infiltrate 5 or even 10 cc's depending on the size and anatomy of the patient. Want to be generous at this stage. Here is sharp dissection along that planned incision track. There is our device incision. We'll just extend that down a little bit deeper before we apply electrocautery to control oozing from the little skin capillaries that we have cut through and to extend that incision down to the pectoral muscle fascia. We don't want to break the fascial plane in any way as that creates unnecessary muscle trauma and unnecessary bleeding. Here we are going a little bit deeper, supported with a wheat lantern, and then now opening the pocket, we will go inferiorly to create a larger pocket where the device will actually sit. So again, we apply copious lidocaine in that inferior pathway, and then with electrocautery, we separate the muscle fibers or the tissue plane staying above the fascia at all times while we create that tissue pocket. Use plenty of lidocaine to keep your patient comfortable. There's no need for patient discomfort at any time while we do this, applying a little bit of extra cautery to make things perfect. And now we will access the vein. I like to use a micropuncture needle to access the subclavian vein where we will pass the lead. Here you see the little flashback of blood into the syringe indicating we have accessed the vein, and there is the tip of the micropuncture needle at the first rib and clavicular junction, which is a safe place to access that vein. We're advancing that fine guide wire into the venous circulation. This allows us to apply this small fine stylet in the venous circulation, and we'll use that stylet now to advance the larger J-tip guide wire through the venous circulation, which will allow us to advance the larger sheath. So again, through the venous circulation, here you see the larger J-tip guide wire through the subclavian, the superior vena cava, through the right atrium, all the way into the inferior vena cava. And when you achieve that, you know absolutely that you have accessed the venous circulation. So we then advance the 8 French sheath or maybe the 9 French sheath into the venous circulation over the guide wire, whichever size the lead manufacturer says is appropriate for the lead that you are planning to implant. We can remove that inner dilator and the J-tip guide wire at this stage. Now we're opening the ICD lead from its sterile packaging. Includes the wrench that we'll need to deploy the set screw. This is a single coil ICD lead, and you'll see that thicker shot coil at the tip of the lead. That's what's able to apply defibrillator therapy from the lead. We typically only use single coil devices at this stage, and here we are advancing that lead through the 8 French sheath into the venous circulation down to the right atrium. And you'll see that larger, darker shot coil there at the end of the lead. Again, that's what's able to deliver defibrillator therapy from the lead. We then place a very sharp pigtail-like curve on the lead stylet so that we can prolapse that lead across the tricuspid valve, avoiding any interactions or interference with the tricuspid valve annulus and valve apparatus by our ICD lead. So with that sharp pigtail curve stylet inserted, we again advance the lead. This allows the lead to curve backwards so we can prolapse the lead across the tricuspid valve. And there you see it in the prolapse position. At that stage, we remove that sharply curved stylet, and then we will advance a straight stylet that will then help that lead unfold through the tricuspid valve in a prolapse fashion. So here we're advancing the straight stylet that will help straighten that lead and advance it into the right ventricle and the right ventricular outflow tract. So with the straight stiletto advancing, we see the lead begin to straighten. There it advances completely, jumping into the RVOT, and from that position we can lower the lead into the body of the RV. We see it fall right here, and then we could advance the lead along the floor of the right ventricle to the apical septum. We want that shock coil to sit on the floor of the right ventricle as apically as possible, but to actually anchor into the interventricular septum where there's minimal risk of lead perforation. Being in that location, we test the electrical signals, ensure an LAO that we are indeed heading into the septum, remove the stylet, watch the curvature of the lead right up over the tricuspid valve, ensure that the shock coil is entirely beyond the tricuspid valve so there's no interaction with the valve apparatus in that shock coil. With these alligator electrical clips, we can then test lead parameters. There we're sensing over 20 millivolts with nice current of injury on the local electrogram. We can deploy the set screw now, actively fixing the tip of the lead into the ventricular myocardium. Usually 8 to 10 rotations of the set screw is adequate. We watch the screw extend on fluoroscopy to ensure that it is adequately deployed. Again, repeat testing after we've extended the set screw, make sure that the lead characteristics are perfect. And with this lead, there is actually an atrial sensing dipole on the lead, which allows us to sense activity in the atrial chamber without having a dedicated lead in that position. Here we are removing the outer guide sheath, peeling it away, removing it from the circulation. As we finalize our implant there, it's removed completely, and this allows us now to advance the suture sleeve of that lead to the tissue interface, and that's going to help us control any back bleeding. And there's the atrial activity on the atrial sensing dipole. You can see that signal comes before the ventricular signal, indicating that it is atrial. Wonderful to have that diagnostic data available to us. We then anchor that lead to the pectoral myocardium. We like to use a non-resorbable Ticron suture, which we first anchor to the muscle with independent ties, and then we will use it to anchor the lead to that pectoral muscle attachment. So here we are doing that suturing process, anchoring first of all to the muscle, and we'll subsequently attach to the suture sleeve. We open the ICD itself, removing it from its sterile packaging. There's the wrench, which will allow us to advance the lead into the ICD header and secure it there. The ICD is larger than a pacemaker, but otherwise a similar shape. This is for the larger battery and the large capacitors that device has to maintain. And here we are tying down the suture sleeve, anchoring the suture sleeve to the pectoral myocardium with that independent tie that we had done previously. There are 2 grooves on the suture sleeve, and we like to place 2 ties on the suture sleeve, always with a tug test to make sure that we are indeed having good purchase of the lead and that it has no ability to translate through those suture sleeves and therefore moving in the patient's body. We insert the connecting pins into the ICD header, and with this dedicated wrench, we deploy the set screws, making sure those lead tips are secure in the header. Again, we use a tug test to make sure that they are secure as we believe them to be. 1 pin for the ventricular lead, a second pin in this device for the atrial sensing dipole, which will give us that atrial diagnostic information. Now we flush the pocket copiously with a antibiotic impregnated sterile saline, remove any debris that has accumulated in the pocket from our cautery, for example, make sure there's no infectious material at all that could possibly remain in that pocket. Make sure there is complete hemostasis and no chance of back bleeding. We then advance the lead through our insertion into the tissue pocket. We want a very snug fit through the skin so we have the shortest incision possible, but then we want the pocket big enough so the device sits very comfortably, putting no stress on the skin once it is in the pocket. And there you can see it's not stretching the skin in any way. It's sitting very comfortably at the base of the pocket, and this allows us to move on to wound closure. For this, we begin with a 2-0 vicryl resorbable suture, so the suture will disappear over the subsequent weeks. We like to close in at least 4 layers, the deep layer being the most important, the most structural layer. That's what we are applying here to pull the muscle over the device. After that layer, you won't be able to see the device any longer, but we'll continue with 3 additional leads, again, to ensure complete hemostasis, minimize the chance of infection, create the greatest pocket integrity for that device, so there's the least chance of any migration or complications or pain down the road for this patient from his ICD. So here we are doing layers 2 and 3. You can see the wound is already closed, but we do these additional suture layers for greater structural integrity. Again, these sutures will resorb, they'll dissolve completely. There we are, anchoring that suture material. And finally, the skin layer, pulling the skin margin together to minimize the scar formation that will occur subsequently and give the patient the best cosmetic result. Here we see the ICD lead in the circulation, beautiful curvature over the tricuspid valve, adequate slack in the atrium. We saw that atrial sensing dipole there in the atrium, which gives us that diagnostic ability. Here we are applying the steri strips and clear or an adhesive dressing over the steri strips, which will be what the patient leaves the electrophysiology laboratory with. Looks very nice. There's our ICD clearly over the costal margin, lead into the right ventricle, adequate slack on the lead, single coil ICD with atrial sensing dipole in the top chamber of the heart.